Hello, everyone. Welcome to the Journal Club of Representation and Rehab. Love seeing some faces here today for our Journal Club. Today, we're going to have two wonderful presenters. The first is Jennifer Addleman. She goes to Touro College of Osteopathic Medicine, and she's an OMS 2. And then we have Jonathan Labampa. He goes to the Chicago College of Osteopathic Medicine, and he is an OMS 3. And so both of them will be presenting today. We also have Dr. Alex Fry. She is a resident physician at Beaumont, and she will be incorporating her input during the Journal Club as well. So without further ado, Jennifer, you can take it over and share your screen.
Okay, let me just make sure that this works. Can you see my screen?
Yes. I also wanted to remind everyone that this is recorded and it will be posted on the YouTube channel so that more people can see. So yes, and we can see your screen, Jennifer. Thank you.
Okay, perfect. Yes, so thank you. My name is Jennifer Addleman. Today I'll be presenting the effects of concussion on subsequent musculoskeletal injury risk in high school athletes. First, just a quick introduction of myself. I am a second-year medical student at Touro University, California. I graduated from UC Davis in 2021. I am also a certified strength and conditioning specialist, which is the CSCS behind my name. I'm interested in PM&R sports medicine. You can see some pictures here of me learning MSK joint injections and performing MSK ultrasound. This interest in sports medicine guided my choice to select the paper that I'll be discussing today. So here's the outline for my talk. I'll be discussing the article starting with the background, followed by hypothesis, methods, results, discussion, and finally, clinical implications. Concussion is a common and serious sport-related injury. The incidence of concussions is approximately 1.6 to 3.6 million per year in the United States. There are many short and long-term effects of concussions on patients, such as alterations in cognition, mood, and balance, and additional symptoms like headaches and fatigue. However, there is increasing evidence that concussions are also associated with neuromuscular impairment, such as during gait activity. This impairment can worsen with added cognitive challenge when completing a gait task. Thus, this connection is of significant clinical relevance with athletes, given that sport activity and specifically gameplay requires significant gait and motor control in addition to cognitive challenge. There have been studies that are indicating that the odds of sustaining an MSK injury were over 2 times that for athletes with a concussion. However, these studies had relatively small sample sizes and only used participants from professional and collegiate athletics, with only a few high school athletes. High school athletes represent a much larger group of the athletic population, and so they are an important group to study given the importance of safety in this age group. So thus, the objective of this paper is to study the association between concussion incidence and subsequent risk of MSK injury in specifically high school athletes. The authors noted 2 hypotheses. The first is that high school athletes would demonstrate significantly increased odds of experiencing a musculoskeletal injury subsequent to a concussion compared to those athletes without a concussion. Then, using the information that prior MSK injury history significantly informs future MSK injury risk, they added a second hypothesis stating that high school athletes would demonstrate significantly increased odds of experiencing an MSK injury subsequent to a concussion combined with a prior MSK injury compared to athletes without a concussion and athletes who experienced a concussion without a prior MSK injury. So there's 2 hypotheses that we're working with. This is a retrospective observational study using historical data from an existing athletic training room EMR system, which included data from 12 high schools affiliated with University of Florida Department of Orthopedic Surgery and Sports Medicine. University of Florida provided these high schools with certified athletic trainers who monitored the athletes for injuries and updated the EMR system. The authors queried the data from the 2010-2011 season through the 2016-2017 season for football, volleyball, basketball, soccer, lacrosse, baseball, and softball of all levels, so varsity, junior varsity, etc. The authors queried the EMR system for time loss injuries. They defined a time loss injury as any injury that precluded the athlete's participation in at least one practice or game beyond the date of injury. They then identified concussion and MSK injuries and recorded them with the time of injury, the gender of the athlete, the duration of time loss, the injury location, and the injury type. The exclusion criteria include time loss not due to concussion or MSK injury, so for example, getting the flu, and athletes with a concussion who experienced a second concussion during the following 365 days. We're going to talk more about that later. The final count was 14,461 athlete year exposures. So it was 5,572 unique athletes. There was 1,193 total cases of time loss MSK injury and 262 cases of concussion were identified. I do have to discuss some statistics, but I'll try to keep it simple. Just as a reminder, our dependent variable is MSK injury. Our first independent variable is no prior concussion. Our second independent variable is prior concussion within the preceding 365 days of injury. And then our third independent variable is combined prior concussion and prior MSK injury within the preceding 365 days of the concussion injury. Categorical measures such as gender and sport were summarized as percentages. Continuous measures such as duration of time loss were summarized as a mean plus or minus standard deviation. A chi-square analysis was used to assess how rates of concussion differed between genders and among sports. And then a generalized estimating equation analyses were used to examine the dependent and independent variables. A generalized estimating equation analysis is basically like a regression model, but it's with longitudinal data, so data that's acquired over time. A secondary analysis was then completed using gender and sport as covariates. We'll talk more about that when we get to the results. With this data, odds ratios with 95% confidence intervals were calculated for each group and compared to each other with z-scores with a final p-value to indicate statistical significance. Finally, the results. The mean age at concussion was 16.4 plus or minus 1.1 years. The mean time loss due to concussion was 16.3 plus or minus 10.9 days. The mean time loss to MSK injury in non-concussed individuals was 30.5 plus or minus 50.0 days, and in concussed individuals was 21.0 plus or minus 25.0 days. The authors do not add any proposed explanation as to why the concussed mean time loss was actually shorter than the non-concussed mean time loss due to MSK injury. They don't really talk about that in the discussion. Male gender and sports, specifically football, volleyball, and lacrosse, were significantly associated with concussion compared to female gender and other sports. Thus, the authors use this information to justify adjusting the odds ratios to use these categorical variables as covariates. We'll talk more about that in the next table. So now we're going to walk through this table, which is the meat of the results. Here we have three groups. We have a no prior concussion group. We have prior concussion alone, and then we have prior concussion and prior MSK injury. And then we have the percentage with MSK injury. We have percentage without MSK injury, and then we have odds ratios for MSK injury compared to no prior concussion group, and then the adjusted odds ratio for MSK injury compared to no concussion group, which again, that was adjusted for gender and sport because there was a significant difference between those groups. So basically, to summarize, this odds ratio is between no prior concussion and prior concussion alone. So between these two percentages is this one. And then between these two percentages is the odds ratio here. And both of these are statistically significant. This odds ratio wasn't listed in this table, but it was described as not statistically significant. We're going to talk more about that in the limitations of this paper. but we'll just take a note now of the small sample size they have in this group. It's only 40. And then these adjusted odds ratios are what was discussed in the final discussion. So these are, again, adjusted for age or for gender and sport. And they are still statistically significant after adjusting for those variables. So just to recap, the first hypothesis was found to be statistically significant with an adjusted odds ratio of 1.67 for sustaining an MSK injury after concussion compared to those athletes without a concussion. So that's 1.67 times the likelihood of having an MSK injury after a concussion compared to without having a concussion. The second hypothesis was found to be partially statistically significant. The adjusted odds ratio of 2.19 for sustaining an MSK injury after concussion in athletes with prior MSK injury compared to those athletes without a concussion or prior MSK injury was significant, but there was no statistically significant difference between the two concussion groups. So that made it only partially statistically significant. The authors compared these findings to previous research. They found a lower odds ratio compared to collegiate and professional athletes. So it was 1.67 times in this study compared to 2.48 times in collegiate and professional athletes. They attribute this difference to faster speed and more challenging level of play, as well as greater pressure to return to field before adequate recovery from the concussion injury for financial reasons and various other reasons. However, the findings are consistent with smaller studies of high school athletes. So it was 1.67 in this study compared to 1.34 in a previous study. The authors noted some limitations. First, they had a small group of concussed athletes with a prior MSK injury for this study. So again, if we go back to the results, there was only a sample size of 40 here versus we have 14,000 here. So there's a big difference between those groups. And so the authors note that there's limited power in measuring the difference between the two concussed groups. We do have a lot of evidence that suggests that prior MSK injury independently predicts future MSK injury. And so it is odd that the results of the study weren't consistent with that. But it does make sense that the small sample size could have affected the result. So second, the authors did not separate athletes out by position within a sport. So they're basically considering a starting running back the same as a reserve kicker, which we would expect to have different levels of recovery after a concussion or an MSK injury. And third, the authors note that injuries sustained while out of season may have been undercounted since they may not have visited the athletic trainers during this time. The authors did not note why they excluded athletes with a second concussion within 365 days. They also did not note how many athletes were in this category. They likely excluded these athletes to simplify the data set to allow the longitudinal data to be estimated more clearly. But however, we know that it is common to have a second concussion after a first concussion. And not only that, it is actually most often within 10 days of the first concussion. So thus this group would probably be good to include in future studies, given the implications on the rehab process for these athletes. It probably just simplified their data to not include them. Finally, clinical implications of the study. Currently, return to play guidelines for concussion do not account for future risk of MSK injury. Once the headaches and the cognitive abilities have normalized, the athletes are sent back to sport with only limited precautions. So in order to work to reduce the number of athletes with subsequent MSK injuries, we could assess and rehab neuromuscular control before the athletes are cleared to return to sport. This could include static balance, dynamic balance, coordination, plyometrics, and possibly most importantly, cognitive challenges combined with any of the above, such as dual tasking. These activities are likely closest to what the athletes need to be prepared for in sport activities and in game situations. So it is important to train these to reduce the fatigue threshold and potentially reduce the risk of subsequent MSK injuries. We could also add a preseason cognitive gait challenge test for high school, collegiate, and professional athletes. If an athlete gets a concussion during the season, we could compare the preseason to the post-concussion test and work to minimize the gap between them. However, we need more research to identify which test is going to be most specific to use for this purpose. But overall, there is a lot of potential here for clinical use and future research. here are my references, and thank you.
Great
Thank
job,
you so
Jennifer. That was
much.
excellent.
Yes, it was great. Thank you so much, Jennifer.
Are there any questions?
Yes, I think we're going to go to questions if anyone has any questions, and then we'll move on to Jonathan after. I actually.
Oh, sorry.
Oh, no, go ahead. Go ahead. I'm sorry.
Sorry. Great presentation. I was just kind of curious about that one slide that you pointed to, that there was like a result that you didn't think that made sense. And I was wondering if you had any, guesses as to why that might be, or maybe it's just based on such a low power based on that 40, N of 40 number.
Yeah, I think it was based on, the authors pointed out that they were thinking that it was because of the low power, and I agree to some extent. There was a big difference between the two sample sizes, and that just in general is going to make it more risk for having, data that's not going to provide a normal result. But there's a lot of evidence that I've seen that indicates that prior MSK injury is highly predictive of future MSK injury. And that's basically what they were comparing between the two concussion groups.
Right.
So I thought it was definitely weird that it wasn't consistent with prior research, but I think that the limited power probably makes sense.
Cool. That makes sense.
I had a question basically along the same lines. There was a result that was not discussed in the paper that you mentioned. It was the mean lost time, I think, for those that had a concussion and those that didn't. And I was also very shocked as to why those that had a concussion, their time was way lower. Why do you think that is? Do you have any opinion on that, and as to why that would be the case? Because it was a significant difference when I looked at it.
Yeah, I definitely thought it was weird, especially because it wasn't just talking about time loss after the concussion. It was actually talking about time loss from the MSK injury. So it had nothing to do with the concussion, but there was a statistical significance between the two groups. So I really don't know why there was such a big difference. It could have been that maybe the athletes were already frustrated that they had time loss from a prior concussion that year, right? And so maybe they just wanted to get back to sport quicker. They were potentially frustrated that they were still, injured and having to take time off. So maybe they wanted to get back into sport quicker, but I'm not really sure. I thought that was an interesting finding though.
Thank you. Any other questions for Jennifer? Good. Okay. So now we'll move on to Jonathan. If you can share your screen.
Let's see how to do this here. Did that work? Let's see.
Yes, it did work.
Yes.
Thank you.
Okay, great. So thanks for joining me us today. So I'll be talking about the biopsychosocial factors associated with attention problems in children after sustaining a traumatic brain injury. So just a little background information about TBI. So about 660,000 children between the ages of 0 and 14 are evaluated in the ER across the US each year due to brain injury. And a third of children who don't have pre-injury ADHD will eventually meet these criteria after sustaining these injuries. And of course, kind of a classic symptoms of having attention deficits are unable to focus, unable to pay attention in class. You can't do more than one thing at a time. You're restless, you're distractible, and you can't really perform goal-oriented tasks as well as others. And so the purpose of this whole paper was kind of to look at the biological, psychological, and social factors that's, sorry, there you go, that influence the development of attention problems after having a TBI in the pediatric population. And so the authors really tried to acknowledge that gap and in our knowledge and research and trying to get a better understanding of what was going on. So why it's important, because we already know that children with TBI are at increased risk of developing these attention problems, resulting in worse functional outcomes, which can manifest as poor relationships or poor school performances or things like that. However, despite us knowing this, there's very few quantitative research articles about protective and risk factors about developing these attention problems after having the TBI. And so by kind of looking at and acknowledging what the risk factors are, we can kind of use that to help guide us in caring for these patients long-term, kind of to optimize their treatment and minimize functional decline, because we know that pharmacologic and cognitive and behavioral interventions will improve attention in pediatric populations, given that they get it in appropriate time. And so just a little bit about the logistics of the study itself. So it's a systemic review of literature, meaning that they kind of, they're trying to find as much relevant research that's been done about a certain topic that they're interested in. And so for this one, it's the risk factors that kind of are implicated in the development of attention issues in these kids. So they use the Medline, PsycInfo, and the CINAHL databases for their article search. And so from April 2007 and August 2020, they did this search 4 times, and they use the keywords I've listed here. I'm not going to list them off because just for time's sake, there's a bunch of different ones there. And so from their search, they pulled 3,480 original articles identified. And so in terms of their inclusion criteria, obviously they wanted to use human subjects. They only took peer-reviewed publication articles, pediatric cohort, meaning the mean age of the population was less than 18 years old, the presence of primary or secondary outcomes of attention problems. If the study had to evaluate the risk factors associated with attention problems after TBI, and kind of this is the most important piece of information, is that they wanted to make sure that there were clinical symptoms of attention problems based on symptoms reported from either the parents or from their teachers at school, rather than using cognitive or neuropsychological tasks. And I think this is just due to kind of the variability that comes with these tasks in terms of reporting results and kind of interpreting what that really means in a kind of symptomatic way. And so for their exclusion criteria, so non-human subjects were excluded. So any animal studies were not included into this paper. Any cohort older than 18 years old as a mean age were not included. Non-English articles were not included. Non-TBI patients, meaning their attention problems were due to other factors, were not included in here. And again, kind of the big takeaway is that if there were no clinical symptoms, they were not being included into the study. And so you can see after all the criteria and stuff like that, from the original 3,480 articles, they kind of narrowed it down to 40 that are going to be included into this. So it's a big jump down. And so in terms of analysis, there really wasn't much statistical analysis done in this one, since it was only a systemic review of literature. So what they did was a methodological quality of individual risk of studies and the risk of bias using the modified Downs and Black checklist. And this is kind of used to pretty much test for the validity of the studies and to see how powerful they were. And so they use those 4 bullet points there: reporting, external validity, internal validity, and power, to kind of assess whether or not these articles were worthwhile including into their paper. And so this little graph right here is kind of a little breakdown of what the risk factors that they're looking for that we'll focus on in this presentation. So injury severity is something that we look at, the age, the sex, the biomarkers, pre-injury ADHD, pre-injury behavior problems, SES, family functioning, parenting behavior, and stuff like that. So this is kind of a really holistic way of looking at the patient and kind of seeing what predisposes them to developing attention problems down the road. And so for primary results, It's kind of a mix. There were some studies that showed that there was no difference between the risk factors that they studied and developing attention disorders down the road. But at the same time, there were studies that showed that these risk factors did predispose those patients that sustained the TBI. And so kind of going one by one, just to highlight kind of what they were getting at in most parts. So one was for severity and the number of TBIs. There was a study done in Taiwan that looked at the rate of developing ADHD based on severity and number of TBIs. And so those with severe TBIs, which was a GCS of 3 to 8, had higher rates of ADHD than mild TBIs, which was a GCS of 13 to 15. And those with more than one TBI had higher rates of ADHD development than a single injury TBI. Additionally, 1,265 children with mild TBI were studied, and that show that there was a higher incidence of development of attention problems among children injured between 0 and 5 years old compared to 6 to 10 years old. And obviously that's due to kind of the developing brain. As you're younger, there's a lot more at risk. And then there was another study done with 148 children that showed inattentive symptoms were increased and more persistent among boys and girls with pre-injury ADHD, which is something Jennifer had said in her presentation as well. And so for biomarkers, it's kind of interesting because there's not much research done about it, or except a couple of studies out there. So they're looking at these specific biomarkers, neuron-specific enolase, S100 calcium binding protein B, soluble neuron cell adhesion, and SE-selectin. And so these studies have found that the serum concentration of these, plus their clinical presentation, can be used to predict attention problems. However, there's not really much research done in the past that kind of quantify this. So this is something that the researchers are kind of pushing for us to do in the future. And then moving on, in terms of having kind of inattentiveness before developing TBI was also seen to predispose you to getting ADHD after having one. So in those without pre-injury attention problems, 32% versus 21% was seen. And then with pre-injury attention problems, 82% with severe TBIs versus 42 with orthopedic injury. So you see that in both groups, control and the treatment or the studied group, there's a huge jump in development of attention orders after having those pre-injury attention problems. And then Max and all showed that poor pre-injury adaptive function, which was problems with socialization and communication, and greater pre-injury psychosocial adversity, and that could be pre-existing mental health problems or mental distress, predicted secondary ADHD development a year and 2 years after injury. And then he also studied the effects of household SES and the development of attention problem symptoms. So within the first 6 months of post-injury, children with mild to severe TBIs from lower income families were more likely to develop ADHD symptoms than children living in higher income homes. And this continued to be true even from 2 years out after injury. And lastly, so family dysfunction in a sample in kids from 3 to 7 years old, it was seen that permissive parenting behavior and increased family dysfunction was predictive of greater behavioral problems up to 18 months post-injury. And I think that this is because that children with ADHD or with inattentive problems, they need kind of more structured time to kind of help them and get what they need. And so this is kind of just a kind of quick overview of everything that they were looked at. So severity of TBI, the more severe, the more likely, the number of TBI, also age of injury, the male gender, existence of pre-injury attentive problems, difficulty with socialization and communication, and lower family SES. And so kind of, I think the study is really important, especially now after COVID. It's getting a good detailed patient history and kind of getting to know the patient and their family and getting to know everyone involved, because it's all this rehab for them is not just the patient themselves but also the people who are taking care of them. And so this study can be really useful in helping us get a better understanding of how we can screen children better for developing attention problems after sustaining a TBI. And by this, we can optimize rehab for these patients and pretty much preventing functional decline, hopefully getting them back to go and back to what they're doing. In terms of limitations, it was a small non-randomized observational studies that were used, so there's not a great deal of evidence. Additionally, since they only use peer publications, there is a risk of bias, which some would say that can overestimate what they were looking for, kind of skewing their results. And the last thing is the heterogeneity of the study designs and measures of attention. So there's not really one uniform way that they use to screen for inattentiveness in this. And so future research, I think it would be really interesting to look at how different interventions kind of protect us from developing, or from these children developing attention problems down the road, and see how effective they are in comparison to one another, or in conjunction with one another. And again, kind of just reiterating what the author had said, is how we can use the specific biomarkers with a good patient history and a clear clinical presentation to see how well or how likely they will have attention deficits in the future. And those are my references, article, and then that's all I've got.
Thank you. That was wonderful. Thank you.
Great job, Jonathan.
Now it's time for questions. So for both speakers. So now's the time if anyone has any questions to ask.
Oh, for Jonathan, do you happen to know why they ended up excluding so many of the studies that they looked at out of those like 3,000? Was it that they didn't measure like the family or teacher reported ADHD kind of manifestations, or?
Yeah, so a lot of them, some of them were animal studies that they use, so they didn't do those. But then again, like you said, some of them were not clinically significant. So there weren't any symptoms provided by the parent or by teachers per se. So if they use kind of like a psychological or some sort of written assessment, they didn't include those either.
Yeah, thank you. Great presentation, by the way.
Thank you.
No? Okay, well, thank you so much to both our speakers. Wonderful presentations. I definitely learned a lot. I loved how concise and how beautifully you laid out the article personally for me. So I appreciate that. And we appreciate you as part of representation in rehab. So thank you so much for coming out. And again, in the chat, Jennifer did put her email. So if you have any additional questions, you can email her. And if you are also interested in hosting a journal club, please contact us so we can get you boarded and get you to present as well in the next journal club. So thank you so much for joining us. We shall see you next time. Thank you.
Bye, thanks.
Sure. Thanks, Jonathan.